So Tecartherapy, in actual fact, has been around for about 15, 16 years clinically. And if you were to look back in the day, it came principally from the Italian, Spanish sporting environments. That's kind of where it made its name in professional football. It was, in those days, quite a passive technology. And so the business I used to run before we founded Winback was very much that. It was an on-the-bed modality. It had been extremely well adopted. But a lot of the younger groups going through were saying to us, look, you know, we don't want a passive technology. We want something that we can develop through the continuum of recovery and then into active dynamic loading at the same time. So can you integrate that into your program? So that's kind of how we developed Tecartherapy. And the whole idea is you have the ability to use manual therapy, and clearly there are schools of thoughts about hands-on, hands-off. But the whole kind of proposition is that if you combine manual therapy with a high-frequency current that allows you to treat acute, subacute, and chronic conditions, or prepare a player for activity, or work with them in the warm down, then you got something that's quite practical. And when you add all those things up together and you look at the emerging literature, and then there is some good things going through. Tim Watson's done a lot of work in the UK on this, particularly in O&E, and that's a good RCT. It took us 7 or 8 years, would you believe, to actually get it from initial idea all the way through the peer review and publication. But that's kind of the payoff. So what we're trying to do is deal with the pain, you know, get that, you know, under control so that we can then start to restore the function. We can then start to get the individual loading and recovering in the right way, and putting all those things together, that we can get an increase in recovery time and injury healing time, but also with the objective that it's a sustainable thing. So it's not just, we get you better, thanks very much. We want to get you back to better than where you were before. So there's a couple of principles, just as this is an introduction, to kind of keep in mind. One is the principle of the intensities that we use in the system itself, in the machine. So when we are working in what we call athermal intensities, down on the left-hand side, 10 to 20% intensity, that's pretty much a metabolic effect that we're having. It's pain gateway. It's not introducing any molecular friction or heat into the system because it's an acute injury. But as we go through the different intensities, and you'll see in the practical side, we start to trigger different effects as we close the circuit between the return plate and the different electrodes that we use. So progressively, you can move to trigger the microcirculation. You can then move up into, you know, in 20 to 40%, 40 to 60, you can get much more of a vasodilatory effect around the tissue. And then on the far right-hand side, when you're dealing with perhaps highly chronic tissue types, it could be tendinopathy or something like that, where you're trying to get the tissue to respond. We use higher intensities but lower bursts. So if you take one thing away from tonight on this bit, at least, it's we create a circuit, we use increasing or decreasing intensities depending on what the objective of the treatment is and the overall assessment of what the patient requires. And then the third element, is the frequencies that we deploy between 1 megahertz, which is very superficial, 1 to 2 centimeters in depth, 500 kilohertz, which is really a frequency where 70% of the work has been done, and then we're treating down to 2 to 5 centimeters in depth in terms of active depth, and then up to or down to 300 kilohertz, where you're getting much deeper into the tissue. And that's one of the things that I've seen in this technology over the last 10 or 12 years or so. It has been quite progressive. You know, it hasn't kind of gone up and down and kind of troughed. There's about 30,000 practices worldwide out there with different approaches on this technology. So if you take that away, complete the circuit, target the effects that you're trying to have with intensity, and then look at the frequency to determine what depth of treatment you're actually trying to get after. So that's just a little introduction. Gareth, do you want to take it from here?
Yeah, absolutely.
I can either press the slides for you, or
yeah, actually, that will probably work. Yeah, for just
so
yeah.
When you want the next slide, just call it up, and I'll put the next one up now. The first one.
Yeah, I could just move on to the next one. I'll just give just a brief introduction. So, thank you very much for having me. And I think my you know, as a clinician, you know, I've kind of covered quite a wide scope in terms of my practice. I would say I'm probably one of the physios that has a fairly eclectic approach to therapy, and I've never kind of believed that, you know, healing actually just resides either with one modality or one way of doing things. And I've always tried to push myself to try and find different ways of working. And I always talk about having tools in the kit box. You never know when you're going to need a particular tool to repair, when you come across something that doesn't quite respond to the ones that your go-to things, or you have patients that, you know, and in particular don't necessarily respond in the way that you'd like them to, and sometimes a different approach is needed. My background really is within elite sport, which I've done now for 23 years, and I've kind of really enjoyed the balance between the two, because I think within elite sport we have the opportunity really to try a lot of the different things that come out onto the market, because we are looking for that 5% difference. You know, that can we get someone back to training even a day earlier, you know, than we would have normally. So it's not just you know, for you know, weeks or a couple of months in private practice, for instance, but actually you really get to know them. You're looking at not only maybe dealing with problems when they come, but they're looking to try and prevent a lot of these issues. And it's and a lot of the protocols and things we've developed and they have translated very nicely to private practice, where you may not have that time to experiment, if I can put it in that way. You've got these tried and tested means, you know, short periods of time to deal with the patient. Quite often it's insurance based, so that gives a lot more restrictions with that. So in terms of you know, my work, I've always wanted equipment which is versatile. I think that's probably my number one requirement. I think I want to, and it's important, especially just to emphasize that it's yes, the equipment and all the different modalities we're going to use are going to help, but it is the knowledge of the clinician and the application of that knowledge that is the most important. Having all the bells and the whistles doesn't necessarily mean you're going to be more effective at treating clients. And I think in particular, this is where I found you know, Tecartherapy, and particularly just working you know, with Paul. It really just offered me a lot of scope in an acute phase, in a subacute phase of injury, and the chronic phase in return to play, in terms of recovery from training. And for me, that is the benefit. You really want to have something where you can apply your knowledge and skill across a wide range of conditions and parameters. So coming through to Tecartherapy, incidentally, I also use a lot of blood flow restriction, which Andy Ray will speak you know, about afterwards. But again, you know, same criteria, very, very versatile and very, very useful. In particular, coming to Tecartherapy, just to understand, you know, the background and how it actually works. I mean, as obviously it's an electrotherapy modality, and one of the things that particularly appeals to me is just the fact that what we're trying to do at a cellular level is to increase the energy of the cellular processes. Once we are able to impart a bit of energy to the individual cells, we are able to effect transfer across the cellular membrane and the plasma. And being able to affect that process is crucial when it comes to stimulating and speeding up tissue healing. We can't go beyond what nature has prescribed is going to happen, but we can certainly, in normal cases, actually help to accelerate that to a small degree. And this becomes really important because the primary thing when we're trying to restore function, and we're trying to, as a result of that, trying to make sure that the tissue is healing, and it's healing in an optimal fashion. This is something that then I would use Tecartherapy for. So we have two different modes. We have the capacitive mode, which here is what we call the set mode. And following on from physics, capacitance is just when the energy is just stored within the head and it's released in packets into the tissue. And it does really provide focal radiant heat to the tissue. And what we're able to do is with that, if there's particular areas, maybe it could be tendon, it could be an area in the muscle which is torn, ligaments, we're then able to impart something very focal and very specific around that area. Now, these are now some of the examples in terms of how we'd progress that. So the TheraBand, as it is there, would have a bracer through the foot, and then the return plate, which in this case is a much smaller version, just strapped in the back there, and you're able to do all the exercise as you would to prevent joint stiffness as well. You can mobilize, with that. You also have the ability to use some of the tools that are available. Obviously, within physio and soft tissue now, we use a lot of instrument-assisted soft tissue, and actually the full version of Winback actually comes with its own instrument-assisted soft tissue, which I've used from time to time, particularly when it's come around to tendon stripping and just trying to make sure that the tendon and the ligaments are healing as optimally as possible. But for me, one of the most exciting aspects is actually the ability to use this as part of rehab. So, in the example, you can see someone doing calf raises, balancing on the bolster as well, on just the little sit fits. Very, very useful, just warming up, but also you're dealing with inflammation as it's happening. You're ensuring that particularly the ligaments and your non-contractile elements are in an optimal environment in terms of elasticity to be able to perform some of these movements. I think, moving forward, Paul, it would be great if we could if it could be non-wired. We'll find a way to non-wire it, then actually to just increase the scope. But I have managed to use a portable unit with a squat rack when I was doing that, and I think it does allow a lot easier mobilization and movement, particularly if it's a lack of mobility in the joints that's limiting the movements as we're going along. So
I hear you, Gareth.
Yeah, just throwing
not
that
as
in.
easy as you might think.
Yeah, absolutely.
But it is interesting because a lot of some technologies are moving the energies into the heads, and you can use your compacts with your Bluetooth and whatnot.
Right. Yeah.
So yeah, it's on the development pathway, but I'm not making any promises.
Just keep here on your toes, Paul.
Yeah. No, I'm here. I'm listening.
Right. So I think again, as physios, we're going to come across muscle tears very, very, very often, and so probably for some of my position, the ones I'm commonly dealing with a lot is will be calf tears, so the gastrocs or the soleus, the hamstrings, the quads, and in the shoulder rotator cuff. And just recently, I've just been dealing with tears in the forearm. So again, the ability, actually, number one, in the early stages to encourage fibroblast formation, to ensure that that process is completed before I start moving onto subacute, where now I'm trying to gain some basic strength around the muscle. In this, in this example, we're looking around the quads, really, that we're working with. But in terms of all the modalities that I would use, I would certainly be using this to a large extent. And I've even lately been using this together with blood flow restriction training, it was just to see what the effects would be. And actually around the hamstrings, so it really worked well. We're able to heat up the hamstrings, sufficiently, particularly fairly deep. And then with the blood flow restriction training, we're able to start to get some exercise happening at particularly deeper levels in the hamstrings. So, but yeah, so again, Tecartherapy will always have a combination of the capacitive and the resistive loads. And quite often in the subacute, we're around the 30 to 40% mark. By the time we're getting into the chronic areas, and possibly for people that slightly bigger people, so think of rugby players, think of people that are overweight, where there's a lot more tissue to deal with. Sometimes you just need to increase the intensity to be able to get the effect that you want from that point of view. This one has definitely been a go-to for me. Coming out of lockdown, the amount of people that try to take up running, and I've come with a lot of running injuries, and it's either been around the knee or it's been around the Achilles, and a few in the plantar fascia as well. And this is really something that I use quite a lot of. So a couple of additional things in terms of you're not only able to manipulate just the intensity that you're getting, but you're also, we talked about the capacitive resistor that you're delivering as packets. You're able to increase the frequency of the packets that you're delivering, and that would be the super pulse. That just means with an increased frequency of pulse, you're going to increase the effect and heat up the surrounding tissue quicker. And particularly for someone with a chronic, Achilles tendinopathy, generally they've been exposed to different modalities already, and there's been limited, and I'm talking things like could be dry needling and acupuncture. It could have been a lot of soft tissue already, taping, if that's been done. They've already been trying to ice, they've been trying to do a lot of the exercises. But the thing about tendinopathy now, and again, this is coming back to first principles, the tissue has been breaking down and trying to repair, breaking down and trying to repair, and we end up in this cycle, and which we need to break. And with that, being able to use either the capacitive or the resistive at much higher intensities, because what we're trying to do really is to strip and to break down some of the scar tissue around the Achilles. And using so I would use the bracelets to do frictions. I'd use the fascial tool as well. And my go-to is definitely the red shock, that high energy, short impulse heat just to the area where it's most painful, to try and break down and strip the scar tissue around that. And typically this would do maybe twice during the week, in addition to the rehab and the things that they are doing on a day-to-day basis. And I've had very good results. And certainly I think it's been something that we've been able to stop as before it gets to the stage of shockwave therapy, although I think the indications are similar in both cases. Right, so and now just moving on to an actual joint. You know, when we're looking through the joint, a lot of the times this is going to focus more on the I tend to use just more the resistive elements to it, because I'm actually wanting energy going right through the joint. So it's not really suitable for the capacitive kind of energy bursts within that. But this really just allows you to do a lot of joint mobilization to get them. Particularly found this very useful post-op, which was probably the other thing that wasn't really mentioned here. But for someone who's had like an ACL operation, by the time the surgeon has released them to the physios at about 6 weeks or so, very, very stiff through the joints. And it's very important. Initially, we're trying to get that full knee extension, and using this to try and heat up, in particular, the joint capsule where there's already been a lot of thickening, and trying to get the swelling down as much as possible, and just facilitating the end of range mobility. This has been very, very useful. So particularly in the first couple of weeks, when you start to see them, when that end range extension is extremely important. I think I'm confident that if I'm unable to get end range extension using these modalities, plus the mobilization, plus any of the active assisted movements that we're able to, that usually I'm happy to send back to the surgeon and say, can you review this, because it may be that it's been a bit too tight. And this is the level of confidence in a rehab situation post-op, that using something like this can, I use it quite extensively as well with a diver we had who had a ruptured Achilles as well. And again, just trying to increase the range of motion initially. As a result of that, we felt this was very useful. They've been in a cast for a period of time. There's a lot of adhesions within the tissue. You've lost a lot of the mobility and of the tissue, the tendon, the muscle has shrunk, and that's where we used a lot of blood flow restriction training to try and build that up. But a lot in the initial phases was using the Tecartherapy to try and gain as much mobility as we were able to. So that's I hope that's given you like a basic overview of and maybe some of the versatility within this. But I think, as was alluded to, I think for me the most important is the understanding of the first principles around healing, around the operations, and what is tissue damage, and an understanding of each of the phases and what we're able to do. And then it becomes really easy to get together your different electrotherapy modalities or other modalities to deploy within those. For me, Tecartherapy has been fantastic, because as I can use it through a wide range of things. So it's not like the old, an example, the isokinetic machine, which is fantastic, but it's just going to sit in one area, can only do work in a very specific environment. And for a lot of us, it's too expensive, and it's not versatile enough in terms of what we're able to do. It's a great piece of equipment in terms of what it's able to do, for what it's able to do, but its versatility and the clinical application becomes quite difficult from that point of view. Thank you very much.